Good afternoon to everyone who's entering the webinar. We're going to give it like a few minutes to let people come on in, and then we will start. Thanks for joining us. Thanks to everyone who's joining. There's still some people trickling into the webinar, so we will start in like 30 seconds to a minute. Thanks again for joining us this afternoon. Okay. Looks like we are down to a trickle of people entering, so let's get started. Welcome, everyone. Thank you for joining us this afternoon. You're here for our emerging conversation, and today we're going to talk about preparing patients for international travel. My name is Eric Ball. I am a primary care pediatrician at CHOC Primary Care Network in Orange County, California. I'm also the district vice chair of the AAP in California and the vice president of the California Immunization Coalition. And I want to welcome everyone to our conversation today. So just some logistics. All the lines are muted during the program. We are going to have just a conversation with our guest today. So we want as much interaction as possible. So please use the question and answer box, and we will try to ask all of the questions to our panel. As always, our webinar will be recorded and posted to the California Immunization Coalition website, as well as our YouTube page. We also have all of our previous COVID and emerging issue conversations posted there. There's almost 20 of them at this point from a wide range of issues. So I hope you can check that out. Next slide. And as always, we wanted to thank our organization, the California Immunization Coalition, and Catherine and Cameron, who always put these together so well. And then we partner with my other organization, the American Academy of Pediatrics in California, which is a joint venture between all four AAP California chapters of pediatricians. Next. And I'm one of your hosts and moderators today. And as always, I'm joined by Dr. Pia Panaraj. She is a professor of pediatrics, Division of Infectious Diseases at UCSD and Rady Children's. She's the director of the aptly named PIA Lab for Pediatric Immunization Advancement. And she is the president of the California Immunization Coalition. Now to our speakers for the day. So I am pleased to welcome our two speakers. We're very Orange County heavy talk today, which makes me happy. So our first panelist is Dr. Kate Williamson. She is a primary care pediatrician at the CHOC Primary Care Network. Full disclosure, she sits 5 feet away from me every day in the office, although not today. So she received her medical degree from University of California in San Francisco, pediatric residency training at Children's Hospital of Orange County, and has been at our practice for like a decade and a half since then. So she not only works full-time in clinical care, but she's also the physician informaticist at CHOC and is an active leader in the American Academy of Pediatrics. She's a past president, among others, in our local chapter in Orange County, and is currently the National Nominating Committee member for the AAP in California. And she is also a media spokesperson for the American Academy of Pediatrics. She is a certified travel doctor in her private practice. And she's the only travel doctor in her practice and is now teaching the other doctors, including me, how to do travel consults locally. In addition to Dr. Williamson, I want to introduce Dr. Jeff Goad. Dr. Goad is a tenured professor of pharmacy practice and associate dean of academic affairs at Chapman University School of Pharmacy. He received his Doctor of Pharmacy degree from USC School of Pharmacy and Masters of Public Health from the Keck School of Medicine at USC. And he completed a residency in pediatric pharmacy practice at Children's Hospital Los Angeles and holds a certificate of knowledge in travel health from the International Society of Travel Medicine. And for over 25 years, he has maintained an active practice in travel health clinics and immunization services. He's also the president-elect for the National Foundation of Infectious Diseases and is the first pharmacist to ever serve in that role. He's a past chair and co-founder of the International Society of Travel Medicine's Pharmacist Professional Group and the past president of the California Pharmacists Association and the first pharmacist president of the California Immunization Coalition. So we're very pleased to have a distinguished panel with us today. Next slide. And I think with that, Cameron, we're going to take the slides down. And I'm going to pass this over to Dr. Panaraj, who's going to get the conversation started.
Great. Thanks, Eric. And thank you, Kate and Jeff, for being here today. So one of the reasons that this emerging issues came about is that, we've seen a lot more cases of measles this year in California and throughout the country. And a lot of that is because of missed opportunities to vaccinate some of our travelers. So maybe we can just start off with you both telling us a little bit about what you do and how you started doing travel medicine in your practice.
Kate, I'd like to go first.
I can go first. Great. Thanks, Jeff. And thanks both Pia and Eric. It's really fun to be here. So I am, as Eric said, a primary care pediatrician, have been not quite a decade and a half, 12 years, but getting very close. And I have really since kind of college and medical school, loved to internationally travel kind of off the beaten path. So that was sort of it's what I did during any vacation I had. I would grab a backpack and make sure my passport was up to date and just go. And so over time, I started learning about just kind of travel tips in general. Then when I became a physician, I talked with some infectious disease doctors and went through some sicknesses myself. I realized as a practicing pediatrician, I know some things that can really help a lot of my patients. And so I did the CDC yellow fever certification online to learn more about that. I talked with a lot of our reps about the vaccines, spent a lot of time just searching around the CDC website to understand what the real risks and benefits were, and then just started being a travel doctor in our practice. And so now I have the opportunity, as Eric was saying, to teach some of our other doctors because it's become such a high demand. I was getting overrun with the number of patients who needed to be seen for this. And it is billable, it is a little time consuming, and I already have a full panel of patients. So being able to teach other physicians how to do it, it's one of my favorite visits at all with patients, and getting them ready for an African safari or going to Costa Rica is just super, super fun. So I'm hoping that with me sharing my story and then Jeff sharing his, that any of us can start giving travel recommendations and even become a travel doctor. It's fun and easy to do.
So my pathway, almost a similar term. I think we all came through pediatrics. So I did my residency at Children's in Los Angeles, and I got to work with some really amazing infectious disease people that really turned me on. Bill Mason, sadly, of course, passed, but Bill Mason was an amazing mentor to me, and was able to really kind of see what vaccinations could do and understanding. We also got a lot of transitioned over to USC. I worked for University of Southern California for 16 years and got a chance to work with some of the LA County staff who saw a lot of things like malaria and other parasitic diseases. So those kind of things converged for me. But one of the things that really turned me on to travel medicine was need. I always like to look where there's a need within the healthcare system that's not being met. And I was in college health. I was working, I created LTBI programs for the university to change our conversion rate from 5% to 65%. Yeah, we started at 5% finishing their course of isoniazid, for example. And so then they turned to me and goes, what can you do with travel medicine? Because our physicians don't like to do it. It takes too much time and it changes every day, right? So I said, okay. And I started the university's first travel clinic in 2000. So since 2000, I've worked in college health and I love it. College age travelers are unique, right? In that they're up for just about anything, anywhere, anytime. So oftentimes we have to prepare them for what could happen, not necessarily what they think is going to happen, which is pretty fun. I spent a lot of time doing group consults as well. that you can do if you have, for example, a missionary group or in my case, a semester at sea group. We're all going to the same place. We can do group consults and then individual consults to make sure they get the right vaccines and medications and counseling and supplies. And ultimately, why I think pharmacy sort of was a good fit for this is that if you think about it, the pharmacist and the pharmacy is a really good place where you're already going to get medications. They're in grocery stores, they're in standalone, and to get pharmacists trained so that they can provide the service, which, the numbers look like less than 5% of the traveling public ever goes to see any healthcare provider. So this is one of those unmet needs that I think pharmacy was a good source to start to get into. But California is unique in that we do have a scope of practice to allow pharmacists to do it, but not across the nation. So that's why I started a travel medicine training program for pharmacists. We've trained now over 10,000 pharmacists in travel medicine nationally, but we're hoping to get more laws changed to allow them to practice to the top of their license. So that's where I am today, and looking forward to the conversation.
Kate, you mentioned something about a yellow fever certification. So if someone on the call wants to do travel consults and travel medicine in their practice or their organization, are there any special certifications, classes, things you need to do, or do you just read up on the matter and get good at it?
So to be able to administer yellow fever, you do need to be certified. So there is a fairly short course on the CDC website. If you search for it, you can find it, and then it's every couple of years to keep it recertified. Just to make sure that you understand, everything that goes along with yellow fever injections and monitoring. And once you have that certification, your office now can order the yellow fever vaccine. But you don't have to do that. For all of the other vaccines, you don't have to be certified through the CDC or anywhere else. You should get comfortable with what the vaccines are. Hopefully, obviously, this talk will help. But just really getting familiar with the places that your patients are going. So I know Jeff and myself, at some time during this talk, kind of walk you through, hey, if you're going to X country, what are you going to do? I think mentally walk yourself through that. If you and your family were traveling to Kenya, what would you need? And start looking through those recommendations and see how comfortable you are.
Well, going with that, maybe we can do that. So Jeff, do you mind kind of giving us a little practice travel consult?
Sure. So
Thanks.
I think to kind of start off, where do we get our information? Obviously, as I mentioned before, it changes frequently. So making sure we have up to date. Fortunately, we have a government agency, the CDC, who keeps up on these things and actually has a travel health division that monitors this. So I'm going to share with you what is available to all of the public as well as providers and is free. And this is the CDC's travel health site. It is interesting in that it integrates the book that those in travel medicine are very familiar with, called the Yellow Book. The Yellow Book gets updated as a standalone text, but all those recommendations are integrated within the Traveler's Health site. And then the Traveler's Health site also has some resources and are written in a way that the general public could also understand. So they're kind of doing double duty with this. Give you an example. I'm going to South Africa in a couple of weeks. So if you start here at cdc.gov/travel, you can pick a country you're going to. Now, this is a single country type of database, meaning that if you're traveling to multiple countries, you'll have to run this multiple times. Right? There are commercial software systems that allow you to do multiple countries at one time, but CDC does one at a time. So if you do this, you click on it, it brings up a little profile. It shows you where you're going, and then tells you if there are any specific notices. This could be health or safety notices that are in here that oftentimes the State Department feeds into CDC if there are any particular civil unrest or things like that. May also show up in here. And then it gives you the vaccines. And one of the things that I really liked about travel medicine and its intersection with vaccines is that we put them all into 3 containers, right? Which are the required, right? As Kate mentioned before, the yellow fever vaccine is really the only one internationally that may be required in certain countries, but then they're recommended and routine. So CDC does that too. And routine vaccines, these are ones that your patients should be up to date on before they travel. Pia mentioned, measles outbreaks within the United States. Globally, they're huge. The CDC or the WHO recently reported just in 2022, there's still 136,000 people died from measles, and somewhere around 57, million deaths between it. It's still, you look at the numbers that are here. It's amazing the number of people that are still getting measles in an era where we have an extremely effective vaccine. So making sure they get their routine vaccines, and then here are the recommended ones that go through here. And they give a lot of specificity. What we do in travel medicine, though, is start to ask questions, which is where are you going and what are you doing, and really understanding who they are. So our special populations and special itineraries. So we'll go through and pick out, for example, maybe they're not at risk for cholera because of what they're doing there, right? There may be cholera in the country, but their activities are not going to put them at risk. That's where the travel medicine specialist needs to weed through these fairly generic recommendations for a very specific itinerary and a very specific person. So you can see all the way down here, does vaccines, and then unfortunately it sort of mixes in an alphabetical order. Malaria, which is not vaccine preventable, but it's a good segue for us to start talking about, for example, if there is a country like South Africa, which has a mixed picture for malaria in terms of where it's spread, being able to pull up a map and show them, here's where you said you're traveling to, what you're looking at is a malaria map. And this is where it crosses, and these are some of the risks associated, and here's what we can do for you, right, as you go through. So you can see it pulls together all of sort of the more common vaccine and non-vaccine preventable, and then breaks it out even further into some more specific diseases for which we may not have a vaccine or a medication to prevent. But what you tell the patient about, for example, avoiding freshwater swimming or bathing in certain lakes and streams could be the difference between them getting something like schistosomiasis and not, right? And then going all the way down through here, they try to do by routes of transmission, right? So you have an idea of what are the big diseases that, again, may be relevant to their travel, may not. The CDC presents a more conservative picture. It's up to you to figure out, as the healthcare provider, what's most important for your patients. And then if you want some counseling things, now they do all the counseling documents. So you could just drop down here. Here's some good food and water sources, so you don't get bit by mosquito. What can you do here? Breakdown. So all the counseling points are also there for you. So the CDC provides a pretty exhaustive list on a country by country basis that a healthcare provider or a patient could use to, prompt you as a healthcare provider. Hey, I just read in the CDC, it says that I might need the rabies vaccine. What do you think? And that's when you put your expertise and knowledge of what's going on there, who they are, and what they're doing to determine if they need that. So that's a quick whirlwind tour of the CDC's travel health site.
Eric, I want to add to that too. When so we've created a protocol in our practice to try to streamline the questions that come in, and when patients are traveling places. Just a heads up for anybody, a lot of times patients will call, they're traveling to a foreign country next week and they need a vaccine. So that happens all the time. So trying to get patients in as quickly as possible in a way that we know exactly what to expect during that visit is important. So I have created a sheet that simply says, where are you going? What are your activities? What are the dates that you're going to be going? Have you had any international travel before? That my front office fills out and gives to me before we even schedule the appointment. I review it and approve it, because if they're going to Kenya next week, they're not going to be able to have the yellow fever vaccine by then. I would need to order it, right? So they would need to go to an urgent travel clinic, not my practice. So I review those. We'll check out the CDC website, as Jeff just showed, just to see if there's any alerts or anything new that I'm unaware of. And then when I do schedule their appointment and they come in on the actual day of the appointment, I will open up that website and make sure there's no more new information or any new alerts, as well as trying to order vaccines that I'm anticipating ahead of time. So I think there's a really good way to sort of anticipate these appointments and know what to expect. I also want to add one more thing to your initial question, Eric, about what do you need to do to be certified? I give the yellow fever vaccine infrequently because there's not that many places, as Jeff was pointing out, that require the yellow fever vaccine. Typhoid, I go through so frequently that I just keep it in stock, always in our fridge. So you'll find over time what you need to store, but you don't have to be a yellow fever certified physician to do travel consults. You can say for any of my patients who need yellow fever, then you send them out and then you see all your other patients. It's totally doable.
Just to add to that real quick, I think Kate, you hit on it. One of the things that I learned early on is good communication with your front office staff. People are making appointments because all those people, those last minute travelers, they were turning away because I would say, I want them to come in 6 weeks before their travel so we have maximum, time to do everything we need. And so they interpret that as, oh, sorry, you're leaving in less than 6 weeks. We can't help you. And would not schedule appointments for that. So communicating with the front office staff, there's a lot you can do the day before. I tried to start a clinic at LAX, right? A travel clinic. So I investigated, priced it out, and now I realize why lattes are like $20, right? It's a really expensive real estate to do there, but there's so much you can do in the hours before they leave, much less, 6 weeks before. So never turn away a patient. You can always do something for them. I agree wholeheartedly with that.
Great, thank you. How do you, because we have a lot of providers on the call who maybe aren't specialists in travel medicine, but it's really important that they, bring up the possibility of travel. So say, at a well child visit or an annual checkup, the provider asks, oh, are you traveling anywhere? And it comes up that they are. Would you recommend that they then create a new visit to fit in, all of the recommendations that Jeff just went through on the CDC website? And that's a question for you, Kate. And then for Jeff, the other question is, could they go to any pharmacy to get their travel medicines?
So it's a great question, Pia. I think, I do think it's nice to have the travel visit be separate from the well visit because there's so much to educate on, and it's really an additional opportunity to teach families not only about the place that they're going to travel, but some basic health things that are even more important when we travel, which is what are ways that we get sick, and how do you make sure that you stay hydrated, right? Some things that are just that much more important when you're traveling. So I would recommend to try to make it a separate visit and using language such as, this is a really important thing to talk about. I want to make sure we make time for this. Could I see you next week, right? So the patient doesn't feel, pushed out at all. I do want to comment one more thing. One thing that's really nice about being a primary care pediatrician and doing travel consults is sometimes I'll see patients that want to come in for a travel consult, but it might have been over a year since I've seen them for a well visit. So it's a good way to bring.
Oh no, did we lose you?
She traveled. Jeff, you want to take over?
Yeah.
Sure. I was thinking about sort of the primary care visit, whether it's in a pharmacy or in family. Oh, she's back. I'll let her jump in.
Oh, sorry, we lost you for about 30 seconds there.
Oh, was that you lost me?
Yes.
Yeah.
Oh, I'm so sorry. Where did you lose me? I apologize.
I think you were saying about scheduling a separate appointment so that and using specific travel terms.
Yes. So I think a separate appointment is super helpful. Also, being a primary care physician gives you, as a travel doctor, gives you an opportunity to bring the patients back to the medical home. So in our practice, you must have had a well visit in the last year before scheduling a travel consult. And so during the well visit, you can review all the routine immunizations, which should be reviewed in the travel consult as well as knowing their medications and any medical complications, so that when you go into your travel consult at a later date, you have all of that information at the ready and you're up to date on that patient's medical information.
And I think, from the pharmacy standpoint, a lot of times community pharmacy is, in a sense, much like family medicine, where they're dealing with all age groups, all different types of conditions. And so I think pharmacists, probably like family medicine, obviously know where their limits are, what they feel comfortable and who they feel comfortable taking care of. And that's why we have referral sources. So understanding, what type of traveler you may be able to accommodate or you feel comfortable or have the expertise to do, and then knowing where the referral sources are. There are travel medicine specialists, absolutely. that are throughout the state, throughout the country. You can go to the ISTM, the International Society of Travel Medicine's travel clinic finder. Another good place to find clinics, for example, Kate mentioned the yellow fever training program through CDC. Well, CDC also runs the yellow fever vaccine finder. So it's part of a nationwide program where all state health departments have to report up to the CDC who their providers are. So there is a national registry of that, which is nice to find out. And usually if they're providing yellow fever, they're also providing a travel clinic. So for pharmacy, if you find one in the yellow fever vaccine finder, pretty good chance that they're providing travel medicine services there, because they probably wouldn't apply for the stamp to get it there if they weren't providing that services. But not all pharmacies, just like not all family medicine or internists will provide travel medicine services. So you do need to find, if you want that full service consult, that you find them, for example, on the yellow fever vaccine finder, on the ISTM listserv, or as a referral source from somewhere else. And then the last place for pharmacy that you'll actually find them is in ambulatory care. So within primary care settings, they may run specialty clinics. You may have them there to do diabetes clinics or CHF clinics or things like that. Well, they also do travel medicine. In fact, that's my area, is out of ambulatory care, seeing patients. So there's lots of different options to find people, but I think everyone, all physicians, pharmacists, nurses, can triage people and figure out where they can help them or where they can send them.
Awesome. We're going to switch gears in a minute and kind of go point by point down some specific vaccines and specific disease states and get your input on it. But before we do, excellent question in the Q&A was that a lot of these vaccines are very expensive and a lot of them are not covered by insurance. So do you have any tips or tricks for patients about how they can afford these or get them in a place where they're not going to be so expensive?
I can start it off. I think
Yeah,
one of
that's
the
a tough one.
things,
Go ahead, Jeff.
one of the things I think has helped is a change in federal rulemaking around Medicare and Medicaid, which require that they be covered if they are recommended. And a big change there was, it used to be recommendation was implied to mean only on the routine vaccine table, right? But that was changed so that if CDC has a recommendation for a vaccine, which they do have, although we're still waiting for the chikungunya one, but which they do have for most all vaccines, they have a recommendation. The recommendation may be very specific to a target population or an epidemiology, but so are some of the routine vaccines as well. So in that setting, I think we have some good coverage. Where it falls apart though is commercial, right? And so that's where people have to do a little shopping around. And there's nothing you can call a place, you know, whether it's Passport Health or it's a pharmacy or a clinic that advertises travel medicine services, and ask them how much their vaccines are. You can price out a yellow fever vaccine. I've seen, you know, wildly different prices for yellow fever vaccine, understanding that it ships at basically the same price to everyone, but different places mark it up differently. So you have to be a savvy consumer if you're outside of the Medicare, Medicaid system. And then some HMOs do provide it, like Kaiser, for example, provides vaccines even for travel for their patients. So it's becoming more mainstream. I'd love all commercial sources to pay for it so that patients don't have to make that decision. Do I want to pay for that maybe expensive rabies vaccine, even though I know that they just told me, especially in pediatrics, you probably get this a lot, you know, kids are our #1 population we try to protect for, you know, rabies, especially dog rabies. So I wish it were better, but you have to be a savvy consumer in some settings.
Yeah, great, thank you. And we also have another comment in the chat that providers noticing that more insurance companies are covering at least part of the cost of vaccines and travel consult. And that's, as you said, it's becoming more mainstream, which is really excellent. So we thought we'd kind of go through a couple of key diseases that we're trying to prevent. And so starting with measles, since that's what really pushed us towards doing this webinar. So can you talk about a little bit about measles and what are the key things that we all should remember?
So I can start with that. Yeah, I'll start with that. So I mean, really, this is, you know, as mentioned again, or before being in the medical home, right? We need to make sure all of our patients are caught up on the routine vaccines and know when we're having outbreaks, which happens way more often than we feel comfortable with, right? And we need to think about any of their travel as high-risk measles locations. So, you know, as we know, we can give the measles vaccine early, even before the age of 1, if there is a high endemic area that they're going to. So it's important for us as travel doctors to also make sure, and their general pediatricians and family practice doctors, if they're going to an area where there is a measles outbreak. You may want to consider giving the second dose of measles early as well. So if they've had their first vaccine at 1, you know, giving the second one at 2 or 3 if they're going to be traveling internationally. So just having that conversation with the family about the reality that, yes, there are mosquitoes that might give you yellow fever. That is a real disease. There is measles, right? So just because it's a routine vaccine doesn't mean that it's any less likely to cause an infection when you're traveling. And in fact, probably more.
Awesome. Jeff, I'm going to have you break out the CDC website again, because would you mind talking about malaria and malaria prophylaxis and when to do it and what to choose?
Sure, absolutely. So if you come over here, for example, on the malaria website, this is, again, it's part consumer, part healthcare provider. Anyone can use it in here. Right? It breaks out, you know, just some of the basics. When I talk to patients about malaria, I think about it in layers of protection, right? The first is, are you at risk? For example, you know, explaining to them that the Anopheles mosquito, which is the culprit that spreads malaria, only bites at night, right? So they're night biters, meaning that if your travels take you back to a city, perhaps where malaria is not occurring, you may not be at risk, right? Depending on what and I see this a lot like in Central America, for example, where they may be going out into a rural area, but coming back before the sunset, right? And they may not be at risk for malaria. But once you determine they are at risk, then you think about the layers of protection. The first are insect netting. So I always talk to people about, you know, if they're going to be sleeping overnight in an area where malaria occurs, can they protect their environment, right? So the more immediate environment is an insect net. Always make sure it's permethrin impregnated. Permethrin is a chemical, it's an insecticide, not an insect repellent. It's an insecticide that really impregnates within that mosquito net. Making sure they have the right mosquito net. Is it 800 holes per square inch? Is it 400 holes per square inch? You know, depending on what they're going to be at risk for. For malaria, 400 is fine. You don't need to be an 800. It's not, you know, for example, black flies are much smaller. You may need 4 holes per square inch. So these are kinds of things that you can help them. Then getting more personal is insect repellent. So making sure that you have an EPA registered, a CDC recommended, like, for example, DEET or picaridin. Internationally, it's known as icaridin. My preference is actually picaridin. I use DEET forever, but picaridin has gotten so much better now, and its sustained action is closer to a 34-35% level DEET. So making sure that they're applying insect repellent to all their exposed areas, and then making sure that their clothing is again sprayed with permethrin. When people get worried about it, I go, just realize permethrin is what we slather on kids' heads for lice, right? So it's very safe, and we only use it 0.5%. That's the actual physical treatment of your clothing percentage. So it lasts for 4 to 6 washings. It's odorless, colorless, doesn't affect anything, but mosquitoes do because they can die on contact. So what I try to help people understand is those are some of the barriers, and the last line of defense is medication. So understanding the resistance pattern, for example, is there chloroquine resistant P. falciparum where they're traveling? Is there mefloquine resistant? They're on like the Thai-Cambodian border. Making sure that you're choosing the right antimalarial for that patient. Can they take something every day, or are they really a once a week kind of person because they can't remember to take something daily? So it's all these different things that CDC puts in here. It actually has on one of their other subsites is a really good decision analysis tool for clinicians to think about all the different questions they should be asking to make sure they get the right antimalarial and give them the right information. And then, you know, again, travel consults are all about minimizing risk, right? We can't eliminate risk, but we can make people feel more empowered and safer. And I like to tell them, when you look at the CDC data for those who return, there's somewhere around 1,500 people come to the United States every year with malaria. Of those, the percentage that did everything that I just told you to do is minuscule, right? Tiny percentage of people slip through those cracks. So this is the way to prevent malaria so that you feel more comfortable on your trip.
I have two quick follow-ups. Can you run through what you're going to choose for your trip to South Africa and how you decided on that medication, if you're going to take a medication?
I am. So I'm going to be in the Limpopo region, which is adjacent to Kruger. And it's one of those regions that's a little in flux. So in other words, that the malaria distribution isn't as well described. If you go to my Safari, right, website, they'll tell you, don't worry about malaria. There's nothing here, nothing to see here, right? So again, one of the things in travel medicine we're always sort of up against is the travel agent industry, which we want to help, but we have to understand what their motivations are, which is to sell tickets, sell trips. And ours is not to talk people out of tickets and trips, but to make sure that they're healthy when they travel. So I'll be doing Malarone, right, once a day, because we're only going to be there for 7 days. Malarone's a great causal protection level antimalarial. So you can start it 1 to 2 days before, daily while you're there, and then once a day for 7 days after you get back. You can stop it quicker than you can mefloquine, for example. So lots of great advantages to that one. That's the one I'm using. And then using picaridin. I like that now more than DEET, although DEET's fine, right? Either are fine for insect repellents.
So I always use Malarone too. Are there other situations, this is for either of you, when you would choose something different?
I only would if there's resistance or if there is an issue with the patient being able to take the pill every day. I actually have not prescribed anything other than Malarone except for one time, and that was just because of a resistance. But Malarone really is a good choice for most of the trips. I would say the biggest challenge, and I'm curious how you handle this, Jeff, is my patients who are going away for a couple of years. Particularly, I get a lot of my college kids heading off into missions. And that's challenging. I often do not medicate them because they really have a hard time getting medication for a 2-year period, and focus on the other layers of protection instead.
I think for Malarone, the one population usually comes to mind is pregnancy. So in pregnancy, actually mefloquine is the category B recommendation, and you shouldn't use Malarone. But in most cases, Malarone is probably the most efficient, most effective medication to use. And Kate, what was that last part you were asking about?
Oh, for patients who are going away for a couple of years on a mission trip, for example.
Yeah.
How you manage that?
Yeah, so usually we look at is maximum time you can be on. For example, like chloroquine has data up to 5 years, but chloroquine has a very small range, like Central America, parts of China. So it doesn't have a lot of utility beyond. Mefloquine does not have as long, a couple of years, although there's some good military data that might extend it a little bit further. Doxycycline, not that you'd want a patient on it that long, but keep in mind you have people on doxycycline for longer periods of time. So if you're going to switch to one, you could also use that. Malarone probably has the shortest amount, usually about a year. But if you have someone who's immigrating, they're going to live there. So, long-term insect repellents and things are probably going to get lost. And certainly the medications, they're going to stop doing those. It's really the expats. As you mentioned, Kate, those people are going to be there for 6 months, a year. That's where you got to get them to keep it up because, we have to tell them you are coming back, right? So you want to make sure that you don't get malaria while you're there. You're going to have to stick with the insect repellent, stick with the antimalarial, but that's because we know they're coming back.
I have one more malaria question, then Jeff, you could stop sharing your screen also.
Sorry.
All right, so very common. We live in an area, we practice an area that is very diverse, very international. We have a lot of people from all over the world. And every day I see a patient who's like, oh yeah, we just got back from like 3 weeks in India or somewhere else, and they never take malaria medicine. They never come to us and let us know that they're traveling to visit relatives. And I've never had a kid get malaria. Is that just dumb luck, or should we be probing stronger on these families who do go travel internationally almost on a yearly basis?
I would call that good luck, maybe not dumb luck. Yeah.
Good luck.
I can start. I'll just talk about one specific population. but I know Kate can definitely expand on the pediatric side of it, which is challenging. So one of the populations that we deal with are the VFRs, right? Those are called the visiting friends and relatives. So within the travel medicine community, it's a defined behavioral group. So in other words, I'll give you an example. Let's say you were born in India, right? You lived there while you were a child, and then at 18, you came to the United States for college and you stayed here, you've been here for 10 years, but now you decide to go back to India for a wedding, for a gathering, whatever you're gonna go back for. Now, what you remember as a kid is, I didn't wear insect repellent. I certainly didn't use permethrin. We drank the water, maybe we boiled it, right? And I never took an antimalarial. Why would I do that now? So you're up against a behavioral challenge. Right? How do you get the people to understand that when you were there, right, you develop a partial resistance to malaria. You probably had malaria many times. Not all of it results in severe disease. So you may have smaller encounters with it throughout your life. You probably had lots of gastrointestinal illness that you don't remember, right, while you were there. And your flora changed within your gut while you lived there versus coming back here where it changes based upon the dietary habits here. And so getting them to understand that, you know what, you may have gone back there, you may have lived there and not had severe malaria, right? But now you're a different traveler. You're used to the United States where you can go outside and the mosquitoes shouldn't kill you. They can annoy you, but they're shouldn't kill you, right? You took a different level of, when you were living in India, different levels of precautions that you probably don't remember when you were there to help protect yourself. And you're unlikely to do that when you go back because you've been living in the United States, drinking the water from a tap, from a drinking fountain freely, and maybe not wearing insect repellent every night when you go out, right? So it's a behavioral challenge for those patients to make sure they understand the risk is still there.
That was exactly what I was thinking of. Thank you so much.
Perfect, thank you. Let's move to typhoid. So what advice do you give to travelers on how to avoid typhoid and other gastroenteritis? And then specifically for typhoid, how do you choose between the oral vaccine versus the IV?
I'll take this one first, Jeff, and then hand it over to you. I'm sure we both have comments. So using Jeff's kind of excellent thought of thinking about skin protection, right? So, thinking about the netting and then the topical on the skin, and the medication, it's good to think about typhoid that way, right? Because typhoid is one disease that you can get through drinking water or eating food that's contaminated, but you can have what we call generally traveler's diarrhea, right? There's many different kind of sicknesses that you can get from GI. So I think first is just talking about how to make sure that you are drinking clean water and how to avoid foods that are grown in water. So I talk about eating an apple versus an orange, for example. An apple may have fallen on the ground, had dirt on it that's contaminated, may or may not have been washed off appropriately, whereas an orange, the covering is taken off, by you. So thinking about what food and what food is touching the ground and trying to avoid that going into your gut is just a good, a good first step. And then I think talking about what signs to look for when you're starting to feel off. So in addition to specifically typhoid vaccine, which we'll talk about in a second, making sure that they're regulating their kind of gut monitoring in general. They need to be hydrating. Our patients need to be hydrating really well. If they start feeling a little bit off, I usually send a prescription for Zofran for all of my patients so they can minimize nausea, so they make sure they stay hydrated if they're not feeling well. Jeff, I don't know if you recommend Pepto-Bismol, but I think it is as magic as a non-prescription medication can be. If your tummy's off a little bit, before you get a traveler's diarrhea, taking some Pepto-Bismol can really, really ward off getting the infection. And then also giving my patients who are comfortable using it, having an antibiotic as needed. So I think those are all things you can do even before talking specifically about typhoid and the typhoid vaccine. In terms of when to do the typhoid vaccine, it really depends on risk benefit. What kind of traveler are they going to do? If they're going to be staying in a hotel the whole time that probably has purified water going through the taps possibly, right? Or they have bottled water in the rooms, they're less likely to be getting typhoid. But if they're eating street food while they're staying in the hotel, then they're more likely to get typhoid. For the vaccine itself, the injectable is nice because it's just easy. And in my office, we have it. But for any doctors who don't have the typhoid in their office, sending a prescription for the oral is also just as easy. And ultimately, it comes down to age, because the oral is it's a pill that you swallow and you take it every other day for 4 doses. As someone who's had both the injectable and the oral, I always have a fear of forgetting one of those days, and then you're only partially vaccinated. And then the other thing is how long it lasts. So the injectable typhoid lasts 2 years, the oral typhoid lasts 5. So if they're planning on lots of international travel, if this is a college kid who's going to be, just taking their passport everywhere, they'll probably do better with the oral typhoid. It'll last them longer. If it's a family who's going to Kenya and for a 2-week safari and no international plans in the future, the injectable might be just fine.
I think that's a great synopsis. That's exactly. Typhoid is one of those tricky vaccines. Hep A is probably easier to give people because it's very ubiquitous, the virus, so it's easy to recommend. But typhoid, you have to talk to them about what they do, who they are. And my thing about, you're talking about what they're eating. I always ask them this question. I say, are you an adventurous eater? And if they smile, I know they are, right? And they know they are. That means they're going to eat that thing on the grill that nobody else is eating. That's them, right? A lot of typhoid is primarily transmitted by contaminated food handlers. Not really as much in the water supply itself. It's more after effect, right? Where E. coli and Hep A gets in the water system. This is one of those after contamination type things where you see a lot of Salmonella typhi that way. So I think the food water precautions are excellent, right? I spent a lot of time doing the boil it, peel it, cook it, or forget it, which is the mantra. And in our Southern Cal population, especially with students, they're all very health conscious. It's very funny to tell them, when you're going to India, whatever you do, don't eat a salad. And they're like, what? Isn't that the most healthy? I'm like, imagine this was grown up through the ground, contaminated with soil. They rinsed it with contaminated tap water, and then slapped it raw right on your plate. All right, when you put it that way. So it's, making it relatable to things that they can control in their environment. They can control not eating a salad, and that may knock out a lot of their risk, at least for E. coli.
Jeff, I think you had mentioned rabies briefly in passing before. Does anyone need a rabies vaccine before they travel? Not except for like vets.
Yeah, I mean, CDC has a really good table that helps to explain the different recommendations based upon, almost all of it are based upon what you're doing while you're there. Rabies is throughout, there's probably, you can count on one hand the number of countries that don't have risk for rabies. So you can assume that there is rabies risk throughout the world. The transmitter varies, but mostly it's dog, followed by bats, but there are also other terrestrial animals that can spread rabies. So you really look at it at how long they're going to be there and what they're doing. And I think one of those big populations that we shouldn't forget are the kids, right? Kids are very likely to pet stray dogs. Adults would go, I'm not going to touch that dog over there, whereas kids might be more likely to do it. So we tend to offer it more to kids. I don't know, Kate, in your practice, do you see a lot of families traveling and they forget about their kids and how friendly they are with dogs?
So I don't vaccinate with rabies very often. It is a couple of doses, and there can be side effects, although I haven't actually seen in my patients with some rabies side effects. But I do counsel on stray dogs, and I will tell my patients directly to that 5-year-old or that 7-year-old and say, I know you love animals, but this is the time to not pet an animal. I think that just having that behavior monitoring is good, and knock on wood, I have yet to have one of my patients get bit by a stray dog. I have vaccinated my patients who were going on zoology expeditions, a patient going off to vet school, as Erica said, but pretty few and far between for rabies.
Yep.
Great. Can either of you talk a little bit about yellow fever vaccine, including if that sometimes travel agencies or some countries will want to see the yellow fever vaccine even though it's not recommended by the CDC. What do you do in that situation, and also what do you do for the very young and the older population?
You want me to
I'll
start?
let you speak to that first.
Sure, I'll start. And so from the yellow fever standpoint, as you mentioned, the first thing we have to do is determine, is it recommended or required, right? And so the recommendations ones are tricky when you have patients who are going in between required locations and recommended. Because oftentimes countries, for example, in Africa will say, if you've been to West Africa, for example, if you've been to Ghana, you're going to have to show proof of yellow fever vaccination. So first, making sure that you're not going to create a consular risk, even though they may not be at a real risk, right? So oftentimes, if they're in a country with low risk, but they still have yellow fever present there, another country may say, I don't know what you were doing there, right? But I want to see that you have proof of yellow fever vaccine so that we don't get yellow fever in our countries, the way they interpret it. So first figuring out if they have the risk, and then determining, do they need an exemption? So one of the things that the International Certificate of Vaccination does allow is for exemptions. For example, if you have a patient who's contraindicated from receiving the yellow fever vaccine, and usually we look at that as if you're immunocompromised. Interestingly, pregnancy is not a contraindication to the yellow fever vaccine. It certainly is a risk versus benefit conversation you have with patients. But looking at the risk in West Africa versus in South America, it's an order of magnitude greater in West Africa. You may actually vaccinate a pregnant patient. And then for the older patients, those over 60, we worry about viscerotropic and neurotropic disease. And so you can go through a little, quick assessment with them about the risk of vaccination versus risk of acquiring the disease while you're there. In West Africa, it usually always shades over to the risk of getting disease outweighs the risk of the vaccine. It's those discussions in Brazil, for example, where you really need to look at their risk and their age versus getting the vaccine. So lots of decisions to be made in there, at least for the older patients. Younger, absolutely too. Okay.
Yeah, as far as the younger patients, I have not yet had a situation where I've had very young patients going to yellow fever endemic areas. Usually you're just not taking young kids on an African safari or to the Amazon rainforest where yellow fever tends to reside mostly. So I think, in those situations, should they come up, we really just need to sit down and discuss what is best for the patient. And actually, Jeff, I just learned something. I didn't know, I have not needed to write anything on behalf of a patient who was not able to receive the yellow fever vaccine. Just for everybody to know, when you do become yellow fever certified, you have special yellow cards, like old school yellow immunization cards, but specifically for international travel, and you get a special stamp that you put on there. And there's a couple different places where you sign your name, the lot number, and all of those things. And then when the patient goes to get the visa for that particular country, they need to take that yellow card with them. You're also supposed to take it when you arrive to the country, although they don't always check at that point. So that's where logistically there could be an issue. And so, I think if you have a situation like that, we just need to figure out how to best write the letter so when they go to the consulate, they can still get the visa because they're not able to get the vaccine.
The vaccine's good for life. So once you get it, you don't have to get it again. And my favorite comment about yellow fever vaccine that's very, very relatable to us here in California is not believing in vaccines is not a reason in other countries. Does not exist as an exemption. That's a US thing.
Love it. We have like 2 minutes left. This has been fantastic. We thank you guys so much. Before we go, Jeff, advice for us. You're going to South Africa. What's in your little pharmacy bag that you're bringing with you? What do you recommend travelers bring with them when they travel internationally?
Yeah, I prefer loperamide over Pepto-Bismol, but I think either is a fine option. And I got some azithromycin in there. I got my Malarone. I got my Picaridin. Treat my permethrin. Treat my clothes before we go. And those are my main things I've got while I'm traveling over there. Plus my vaccines, of course. But
Kate, anything you would throw in there as well?
All of those. Also melatonin. If I recommend for my patients who are traveling at least a few time zones away, or particularly like other side of the world, take melatonin at bedtime in your destination. That has saved off a lot of abnormal sleep for me traveling. And calamine lotion. So Jeff, I don't know if you've used this before, but for bug bites, a combination of hydrocortisone cream goes in first, calamine lotion, you slap that on second, and that seems to help with a lot of the bug bite itchies.
Yep.
Great.
advice.
And one last very quick question for both of you. If you know, we have some people on the call who are still a little bit uncomfortable about travel medicine, but want to start offering travel advice in their clinic, what advice would you give to them?
I would say just start surfing around the CDC as if you were taking that travel trip yourself, and you'll find how quickly comfortable you are. It's a very well executed site. And then second, surf on it when in the patient room. Just say, hey, you're going here, let's look together, and let them know that you're kind of learning this too. And it's always okay to say, I don't know.
And again, if less than 5% of the traveling population sees anyone, you have a lot of knowledge that you can impart on patients, or you can refer them to people if you think they need, you know, a higher level of travel medicine. So definitely ask that question, are you traveling? Otherwise, you'll never know.
Perfect. Thank you so much to both of you. I think this was very helpful to have this conversation. For the audience, please remember to fill out the evaluation survey for today's webinar. This really helps us a lot as we prepare future webinars. Next slide. We have a couple upcoming webinars. So there's the Physicians Advisory Committee Vaccines for Women. There's a registration there. Advancing Adolescent Immunizations presented by the HPV Vaccination Roundtable coming up. We also have two more emerging conversations coming up, one at the end of the month, August 27th. That is going to be about the new COVID-19 vaccine that's coming out, we expect in the next 3 to 4 weeks. So we'll talk about that. And then in early September, September 10th, we will talk about delivering protection maternal vaccinations for RSV in pharmacies and obstetric practices. So that'll be great for all OBs, as well as all the pediatricians on the call learn about how the OBs discuss shared decision-making with the pregnant moms. All right. So again, you can find previous emerging conversations on our website or our YouTube channel that's posted there. And this webinar will also be posted in the next day or two. And I think that's it. So thank you very much to everybody for attending today. Have a good rest of the afternoon.
Thank you.
Thank you.